Hello, everybody in podcast land. I'm Dr. Ted Thatchencary, and this is MD Roundtable, a podcast about collaborating and learning from other healthcare professionals from all over the globe. We are all so much more connected due to technology. We have so much to learn from each other. Thanks for joining us today at MD Roundtable. This is a very special episode as we are featuring Dr. Anita Asgar, who is Section Chief of the Interventional Cardiology and Medical Director of the Structural Program at the Bluhm Cardiovascular Institute at Northwestern Medicine in Chicago, Illinois. Welcome to MD Roundtable, Dr. Asgar.
Thanks, Ted. It's great to be here.
Pleasure to have you. Anita, I understand that you just recently moved from Canada to Chicago, so welcome.
Thank you.
Yeah, did you grow up in Canada? Where did this all start?
It's a funny story, actually. I'm from Newfoundland, and I've sort of trained all over Canada and spent the last 15 years in Montreal, but we had a family connection to Chicago. My father's brother had lived here for many years, and when the opportunity came up to move to Northwestern, I took it.
Fantastic. Anita, who was your biggest child influence on becoming a doctor?
Well, I'd have to say it's probably my dad. He was an ophthalmologist. So I grew up sort of going to the hospital with him when I was a kid. And we had discussed, like young children do, what do you want to do when you grow up? And I had said to him, Daddy, I'd like to be a nurse. He said, well, that's a great choice. Have you thought about being a doctor? And I hadn't seen a lot of female doctors, actually. Growing up, I actually hadn't met any. I said, well, I've never seen, a doctor who's a girl. And he said, well, girls can become doctors too. And, many years later, that's where I found myself.
Wonderful. Did you end up going to med school in Newfoundland?
I did. I went to Memorial University in Newfoundland where I trained. I did internal medicine there. And then I moved to Halifax, Nova Scotia to study cardiology.
Great, great. And then did you basically start working in Montreal right after that?
So I'm actually an interventional cardiologist. And so I did my interventional training at the Montreal Heart Institute. I did 2 years there and then actually moved to London across the pond to study what became later known as structural heart intervention. After 2 years there, then I went back to Montreal at the Heart Institute and worked there for 15 years.
Great. This episode is brought to you by Paraflight Aviation and UrgentFlights.com, where top tier service meets cutting edge technology. Founded in 2016 by flight paramedic Sim Shan, Paraflight Aviation is a premier corporate jet charter brokerage specializing in corporate executive travel and organ transplant flights. With the commitment to safety and efficiency, Paraflight has quickly established itself as a leader in the industry. What sets Paraflight apart? Their innovative app, UrgentFlights.com, operates like Uber for aviation. This powerful tool allows them to source aircraft rapidly, accessing over 200 operators and 1,500 aircraft at a moment's notice. Paraflight is not just about speed, they fly hundreds of life saving missions each year, 24/7. Their dedicated dispatch team and meticulous concierge service ensures that every detail is handled with the utmost care. Whether you're transporting your executive team or facilitating a critical organ transplant, Paraflight is your trusted partner. Ready to elevate your travel experience? Visit paraflight.aero or call 844-538-1911. Once again, 844-538-1911 to learn more. Paraflight Aviation, one team, one mission, saving lives. Anita, what have been some of your biggest challenges that you've had to overcome?
In general or in medicine?
In medicine.
I would have to say learning another language. So I decided to train in Montreal because it was an amazing center. But the center I trained at was actually a French hospital. And I knew a little bit of French, but I would be hard pressed to say I was functional. to
Hmm.
work in a hospital. And so, as a fellow, I learned French during my interventional fellowship
Wow.
so that I could work there. And learning another language when you're older is not the easiest thing. The people I worked with were patient and kind, and it's amazing what you can do when you don't have a choice. So I would say that's probably one of the hardest things I've had to do is to learn a new field and then learn it in another language.
Right. That's very impressive, Anita. Yeah, that's sounds like it's very challenging, but wonderful. Okay. So, did you know early on that you wanted to go into cardiology? How did you make that transition?
So I would say, my father is probably the influence there as well.
Mhm.
And so he'd had his first heart attack when I was only 2 months old.
Ah,
And so I grew up in a family, with a physician, but I grew up in a family with heart disease and watching him go through all of that, all the different treatments and, what was new. And he had open heart surgery when I was actually in medical school. And I think that impacted me a lot, understanding from a family perspective, what you go through as a family member of somebody who has heart disease, and watching them go through the different treatments, the different steps when he had a defibrillator, all those decisions, I was there with him. And I think that really played a big role in why I chose to be a cardiologist.
yeah, I could definitely see that. My father as well has suffered from heart disease, so I can relate. I guess,
Hard.
being
And I think it does, though, give us a great perspective when we talk to patients and their families because we've been there.
correct,
We've lived it. So I think, it helps me do my job better.
correct. So, Anita, I'd like to get into the meat of the discussion here about aortic valve disease for our listeners. I know you're a structural cardiologist. Can you explain what the function of the aortic valve is?
Sure. So, we do have four heart valves. And so each of these valves are essentially controlling the flow of blood from one chamber to another. And they control, the separation of these chambers. And so the aortic valve is the valve between the left ventricle, the major pump of your heart, and the aorta. And so it controls the flow of blood out of the heart into the aorta. And so this is obviously the most important because once blood comes out of the heart, it goes to your brain, goes to your kidneys, it goes to all your vital organs. And so this valve is important to make sure that the blood flows in the right direction. If it leaks, blood goes backwards and it goes into the left ventricle, makes the pump less efficient. And obviously, if it doesn't open enough, you're unable to get the appropriate amount of blood flow to your brain and to your vital organs. And so it is arguably probably the most important heart valve. They're all important, but this one probably has the greatest impact on patients.
Yeah, thank you for explaining that. What is aortic stenosis and what are some of the causes of AS?
Right. So aortic stenosis is a term we hear a lot of the time affecting patients as they get older. And essentially, if we go back to that heart valve, when it becomes narrowed over time, and if you imagine your garden hose, if you have obstructions in your garden hose, if you have a kink in your garden hose, the flow of water out that hose decreases. The aortic valve functions much in the same way. So when it opens, it allows the blood to move forward. But if there's a problem with the valve such that it cannot open properly, and that's what we call aortic stenosis, the flow of blood outside of the heart to the aorta and to your vital organs is diminished and decreased. And then we suffer from that and we have symptoms associated with that. It's relatively common as we get older because this is a valve that opens every time your heart beats. And so the most common cause of aortic stenosis is something that we call degenerative disease, meaning the valve just basically gets worn out. It's functioned, however many thousands of times, and now it doesn't open well. It tends to get calcified as we get older, and so that impedes the valve from opening properly.
What is the prevalence of AS in the general population? I know that as you get older, we tend to get more calcification.
So it increases as we get older. And so from probably 40 to 80, it gradually increases. 40, the incidence or prevalence of aortic stenosis is quite low. Once you get over the age of 70, 75, it can go up to as high as 10% in patients as they get older. It varies depending on what other medical conditions you have, but in general, it's probably around 10 to 12% in the older age groups.
I see. Okay. And is there a gender preference for AS?
Not necessarily. It seems to be kind of evenly spaced between males and females. So there's not one sex per se that's affected more. It really is sort of an age dependent condition.
Okay. And when one has clinically significant aortic stenosis, Anita, what are the usual symptoms they might find?
Right. So if you're a patient with aortic stenosis, probably the earliest sign that you may notice is that you get a little bit more breathless when you're doing physical activity. So shortness of breath is one of the classic symptoms of aortic stenosis. And as you can imagine, as the valve becomes more and more blocked or obstructive, the quantity or the type of symptoms change. So the symptoms get more frequent as the disease gets more severe, and then they can involve other things. So it may start with breathlessness, or you're short of breath when you're walking upstairs, carrying groceries, even going for a walk on a flat surface. But as that disease progresses, people may start to notice they have chest tightness or pain in the chest, almost like they're having an angina attack. As that progresses even further, we start to get symptoms of what we call heart failure, where that breathlessness increases even more, but you may notice some swelling of the ankles, some fullness around the belly, and so other symptoms of what we call heart failure.
I see. Okay. And does everyone with a bicuspid aortic valve develop aortic stenosis?
So it's a great question. So when we talk about bicuspid aortic valve, I guess it's important just to remind people what that means. So the aortic valve in general has three leaflets, or it's tricuspid, as we call it. It looks like a Mercedes-Benz sign, in fact, when it's closed. There are some people that are born, and it's a congenital abnormality, meaning you're born with it, where they have two leaflets. That's the bicuspid type of disease. So people who have bicuspid aortic valve disease, basically what that means is you have two leaflets instead of three. Unfortunately, associated with that, because the valve isn't what we would consider to be normal, the valve doesn't always respond to the stresses on it in a normal way. So it tends to either leak earlier in life or get stenotic or obstructed earlier in life. And when I talk about earlier in life, it can be as early as anywhere from 40 to 60 or even younger, depending on the valve itself. And so, not all bicuspid valve disease is stenosis. Some of it is actually leaking. The exact percentages I can't tell
Mhm.
you off the top of my head. It varies, but you can either have bicuspid aortic stenosis or you can have aortic regurgitation from bicuspid valve disease. Stenosis is a little bit more common, obviously, as patients get older, but the valve can leak as well.
I see. Thank you for clarifying that, Anita. What are some of the common ways to diagnose aortic stenosis?
Yeah, so the easiest thing is to have somebody listen to your heart. And, a physician listening to your heart can try to detect a murmur. It's not always specific for aortic stenosis, but at least it will tell your care provider, your family physician, that there may be something going on there. The next test is obviously what we call an echocardiogram, which is an ultrasound of your heart to evaluate the valves, to look at the valves, see how well they're opening and closing, if they're leaking. And so an echocardiogram really is the test of choice to diagnose aortic stenosis.
Got it. Okay. And this is just your standard transthoracic echo. You wouldn't necessarily need a transesophageal echo, correct?
Absolutely. So we start with a transthoracic echocardiogram, and if that's not sufficient or there's more data that we need, a transesophageal echo would probably be the next step, or a CT scan would be another option.
Ah, okay. What are the options that are available for those with symptomatic, clinically significant aortic stenosis who are considered high risk to undergo surgery?
Yeah, so obviously, in the years that have passed, open heart surgery with aortic valve replacement had been the treatment of choice for patients with aortic stenosis. To your point, patients who are considered high risk for surgery, we are thankful to have another option, which is transcatheter aortic valve replacement, or TAVR. Essentially, what that means is that physicians are able to replace the valve without removing the existing valve, and they do this procedure with a catheter. And so a catheter goes in the groin with a valve inside it. It goes up into the aorta, and we're able to place a new valve inside the diseased valve using a catheter procedure. Usually takes anywhere from 30 to 45 minutes. Patients can frequently go home the next day or the day following the procedure.
That's great. I know it's becoming a lot more popular. I believe I saw that 90,000 TAVRs were done in 2024 in the US alone. How long has the technology been around?
It's a great question. It makes me feel a little bit old. But when I was a fellow in 2006, we did the first, what we call self expanding. It's a type of valve, TAVR in North America in Montreal. So essentially, the entire span of my career, we started this procedure, and it's been a fantastic journey to watch from first in human type of procedures that we were doing to kind of day to day practice. And so this technology has been around for 20 years.
Hmm.
It's been studied extensively, and it is really the treatment of choice right now for patients who are high or prohibitive risk, even intermediate risk. It's a reasonable alternative. And in fact, also what we consider low surgical risk, it's a reasonable alternative once a patient's been appropriately evaluated by a multidisciplinary heart team. So certainly it's a treatment option for more and more patients. To your point of 90,000, I think we're only going to see this continue to grow.
Yeah, definitely. What you mentioned it's low risk, but what are the risks involved? And do these patients require long-term anticoagulation?
Yeah, so the risks are never, unfortunately, going to be zero anytime we're trying to do a procedure for a patient, but the risks are low. And so when we think about risks for these types of procedures, bleeding is one of the most common complications. We are putting catheters in the arteries, in the groin. For patients who may or may not have what we call conduction system disease, so patients who may have an electrical system of their heart, which functions perhaps a little bit slower than usual. They may require a permanent pacemaker after the procedure is over. And there is always a small risk of stroke when you're doing a procedure like this. We are taking a catheter going up past the brain. And if there's any calcium or atheroma in the aorta, there's always a small possibility that a patient may have a stroke. These are the three major complications. Thankfully, they're very low these days with the new technology we have. Pacemakers are a little bit higher, maybe around 9 to
Mhm.
10%. Risk of stroke is generally less than 2% from the data we've seen in the US. And the risk of bleeding varies. It really is patient dependent, depending on the size of the vessels, body habitus. And so these are the most common risks, I would say, the things that we worry about. But certainly at acceptable risk levels, I think, for patients for a disease which, if we don't treat, ultimately will progress to death,
Mhm.
unfortunately. So.
And do they require long-term anticoagulation or no?
They don't. So this is a biological valve that we are putting in. And so unless they have a previous reason for needing anticoagulation,
Mhm.
the placement of this valve does not require patients to be on anticoagulation.
That's good to know. Anita, what have the studies using TAVR shown versus surgical aortic valve replacement? What have they demonstrated so far?
So recently, what we've seen is some long-term studies that have shown us that essentially out to 10 years, the biological valve we insert by catheter is almost equivalent to the surgical valve in terms of durability. So, one of the questions we get from patients is if I have a catheter valve versus a surgical valve, is one going to last longer than the other? And the answer is no, they're probably equivalent. The other thing we have learned from the studies over the years has been that in terms of patients, as we mentioned, at low, intermediate, and high risk, if you're high risk or prohibitive risk, you're probably better off being treated with a transcatheter procedure or TAVR than surgery because the risk is somewhat lower and patients did better. If you're intermediate or low risk, TAVR is what we consider to be non inferior to surgery, meaning it's not better, it's not worse. I can't really say it's
Mhm.
equivalent for statistical reasons, but It's not inferior. So it's the translation of that is it's a good option for you if you're at low and intermediate risk, and the team evaluating you thinks you're a good candidate.
Great. That's amazing. What do you see in the future in the field for management of AS?
So obviously, the issues that we still think about, I mean, we've come a long way from doing, first in human cases to where we are now, but we can always do better and we can always improve. And I think areas of improvement, love to see the pacemaker rates come down. We'd love to not have to give patients pacemakers if they don't need
Hmm.
it. Obviously, durability is an issue because if you take a patient who's 70 and you give them a transcatheter valve, chances are good they're going to need another one, maybe at around 84 or 85 years old. And so, trying to find ways to improve valve durability is going to be important. And biological tissue, even our own, eventually will fail and it needs to be replaced, hence the patient's requiring a valve replacement. And so then I think we need to focus on, if you do need another procedure, making sure that we can plan that well and we can make sure that patients have a good option when that additional procedure comes up. So I think those are the main things that we're looking at now: valve durability, longevity, and planning for the future. We call that lifetime management.
Hmm.
You put one valve in a patient, but that may maybe not be the last valve that they're going to need. And so we need to be thinking about that at the time that we do their first procedure.
I see. Thanks for explaining that so eloquently, Anita. Are there a lot of biotech companies that make this valve or just a few?
So right now there's I would say a couple of very big players in the market, but technology is changing, and as a physician, we're lucky to be in a situation where we have lots and lots of options. So, there are probably about four big companies that have valves out that are three that are commercially available. There are other companies that are in the research phases doing trials with new technology. I think that's amazing for
Mhm.
patients because as a physician, I'd like to have many choices so that I can select what's the best valve for the patient in front of me.
Right.
We're not all the same size, we're not all the same. One size doesn't fit all. So the more options as a physician that I have, the better I think I'll be able to treat my patients.
That's right. What's the biggest surprise you've had in the last few months or years in this field?
In aortic or just in structural heart disease in general?
Yeah, in structural heart disease.
One of the things I think has been amazing is seeing, structural heart disease used to just be aortic stenosis, and to see how the field has evolved over the past 15 years. Treating aortic stenosis is becoming more of a routine procedure. But there are other valves, as I mentioned before. We have four of them, three that are particularly important: aortic, mitral, and tricuspid. And I guess what I find amazing is that, we have newer and newer technology that is able to treat patients. Particularly tricuspid is a space that is exploding with all kinds of new technology.
Mhm.
It's a disease that's, less, has a lower mortality perhaps than aortic stenosis, but patients are sick and they have a lot of symptoms, and their quality of life is quite affected by tricuspid regurgitation in particular. And what I find amazing is how the technology, we can dream it and the engineers can build it.
Yeah,
And, there's just newer and newer devices that are becoming, I wouldn't say available, but at least in the research side, available to see if we can help improve patients. So I think that's what's encouraging, and shows the field is just continues to grow.
great. How do you continue to learn and stay up to date in this field?
It's a challenge because there's always new information coming out. It's interesting. Back in the day when I went to school, everything was in the textbooks, and you had to buy the new version of the book that was out. I mean, we're far from that now, and so, everything we learn now is probably at conferences, on the internet. It's amazing the way we're all connected. You can see somebody doing an amazing procedure in Europe somewhere in a hospital you've never heard of,
Mhm.
and somehow you can still reach out to them and learn from them. And so I think it's made the global community a lot more connected. And so we're able to learn from our peers in a way we never really could before. But it's still a challenge. It's hard to keep up to date. I think social media and the various platforms have made it easier for us, but it feels like a 24/7 kind of job.
I bet. I bet. Yeah. What are some of the things that, well, you kind of talked about it already. I was going to ask you, what are some of the things that excite you the most right now in this specialty?
I mean, I'm a person who loves to learn. And so I think what
Hmm.
keeps me motivated and keeps me interested is how things keep changing. And there's always an opportunity for me to learn and to get better, be it new technology or understanding a disease better. I just think it makes me better at what I do. And it keeps you engaged. It's not like we do the same thing, every day for years and years. It's always changing.
Yeah. Good for you, Anita. What are some of your interests outside the hospital? Like, how does Dr. Asgar like to decompress?
So I think my two favorite hobbies are reading and cooking. Unfortunately, with the cooking comes the eating, but I do love the cooking part. Yeah, no, and reading has been one of my passions. I enjoy reading. There's nothing better for me than to sit down with a great book and spend a couple hours just reading a book. I don't always have as much time as I would like,
Yeah.
and I enjoy cooking. I mean, I just love being in the kitchen and cooking
Great.
for the
Yeah.
family. I think it's great.
Is there a certain dish or type of food that you enjoy cooking?
I mean, I'm Indian, so that for me is my comfort food. I'm definitely not as good as my mother, and I struggle with her recipes because I can never make them taste like the way she
Yeah.
makes them. There's something missing, I'm sure of it. But I think that's what I enjoy the most. Cooking food that reminds me of home.
Yeah, that's awesome. Well, listen, Anita, welcome to Chicago. I think Northwestern is lucky to have recruited you. And I want to thank you for your time and taking the time out to be a guest on MD Roundtable.
Thank you. It's been a pleasure, and I look forward to exploring the city and the restaurants while I'm here.
Yeah, definitely. Yeah, a lot of good food in the city. So, all the best to you. Thanks again.
Thank you.
Have a good day.
You too.
Folks, if you enjoyed that episode, don't forget to leave a review of MD Roundtable Podcast and don't forget to subscribe. Also, if you want to reach out to me with any comments or questions, feel free to go ahead and email me at drtedthatchandcarey@gmail.com. Once again, Dr. Ted Thatchandcarey@gmail.com. I will also leave the email contact in my show notes. Thank you again for joining me. Have a great day.